have to admit, manual expression might secretly be my favorite part of the whole process. And my last preceptor would kind of make fun of me because I would get so excited to do the manual expression.
Hello, listeners. Welcome back to episode 2 of Blink Collective. I'm Mackenzie.
And I'm Lisa, and we're your co-hosts.
Yes, if you joined us for episode 1, thank you for coming back.
And if you're new here, Blink Collective is all about conversations happening in optometry right now, from clinic experiences to new technology to things students and new ODs are actually talking about in our group chats.
Yeah, exactly. And today we're diving into a few fun segments, starting with one of our favorites.
Yep, it's time for our hot takes.
Yay.
Okay, Mackenzie, I have a hot take.
All right, Lisa, let's hear it. I'm ready.
Okay, I think it's time we talk about the presbyopic drops.
Ooh, yes, that one's exciting and a little spicy, if you know what I mean.
Yeah. So we know we got 2 big ones on the market right now.
Yes.
We have Viz and Closey. Viz being 1.44% aceclidine, and Closey being a more dilated pilocarpine at 0.4%. We previously had Vuity, which kind of flopped, and that was 1.25% pilocarpine.
Yeah.
So let's start to talk about these drops here. Have you worked at an office at all that prescribed any of these drops, Mackenzie?
Yes, so when I was an undergrad, I worked in an office that prescribed Vuity. So my mom actually used that for a little bit right when it came out because she is a hyperope that claims she doesn't need glasses for distance, so she doesn't wear anything and then just makes everyone else read the menus for her.
Yeah.
She's gotten better though, so that's okay. But she used Vuity, and then some of the externship sites I've been at have used the Closey and the Viz. So,
Okay.
what about you?
Yeah, one of my rotation sites, we kind of would prescribe the Closey and the Viz. We kind of give them both at the same time, let them start with Closey, kind of see how they did, and then that way they had Viz to try if they felt like they needed a little bit more of a boost. And
Yeah, that's an interesting approach.
Yeah, definitely.
Yeah. I think something that, we need to talk about and be aware of as the doctor's prescribing them, though, is definitely the side effects and some of the stuff that comes along with it, because they're definitely important to be able to warn your patient about.
Yeah. So let's talk about some of the side effects and some of the things that you kind of have to be careful with these drops. So with Viz, from what I've been hearing, the biggest side effects are the stinging upon installation.
Oh, she's spicy.
Yeah, I've heard it can be a little bit, at first. And then also with Viz, like the dimming effect part of it as well. With Closey, kind of what I've been hearing, and you can chime in if you have any more thoughts about this, Mackenzie, but what I've been hearing is that it also has a little bit of a dimming effect, but not quite as bad as Viz.
Okay.
And then, obviously, with a drop that has Pilo in it, you kind of have to be careful with one adverse side effect, Mackenzie.
Let me think. Retinal detachment?
Oh, yeah. Good job.
Something that still is scared of us from episode 1. We still have not seen one. It's been a few weeks. And
Yeah, still not seen one. I'm waiting for the day to come, though.
Me too.
But yeah, so with Closey, you want to make sure you do a thorough dilated retinal exam before prescribing to make sure they don't have any risk factors, kind of putting them at a higher risk for that retinal detachment. Now, Mackenzie, I would love to hear, I know you have a little story.
Yes. So I have gigantic pupils.
Gigantic.
And I had refractive surgery, so my pupil gets way larger than my treatment zone at nighttime, so I cannot drive at night without using Alpha-GAN P is what I've been using, but obviously I don't want to use that as often as I necessarily need to, just because I don't want to end up getting the follicular conjunctivitis and the allergic reaction part of it.
That wouldn't be fun.
So I'm always looking for something to test out and try to see if there's an alternative that I could kind of, either rotate in between or just kind of use instead. So First years when I had my refractive surgery and when we had like our optical kind of rotation period in the summer, I tried Vuity, and that was awful. It literally took all my vision away. Like, I was freaking out because I was like, okay, yep, I just got the retinal detachment. Like, I cannot see anything.
Yeah.
So it really affected my distance vision.
So was the dimming effect like super, super bad with it too?
I honestly, it's been so long, I don't remember the dimming effect. The only thing I really remember from it was that I could not see, like, my distance vision was so blurry. Like, I had to not work for a good, like, 30 minutes to an hour because I literally could not see.
Yeah.
It did end up coming back, so it was fine, but that was just a little, like, scary. And then over the winter externship site, I tried Viz. So first off, that literally made my eyes so red. Like, it hurt so bad. It hurt, like, I cannot even describe how badly that hurt. And then for a good, like, 20 minutes, everyone in the office was like, are you okay? Are you okay? Are you crying? I'm like, I'm fine. I just, like, my eyes really are hurting.
Yeah.
But then after that went away, I just got like a really bad dimming effect from it. So my vision was fine. I wasn't blurry or anything, but it was just like I was sitting in a dark room. So it was definitely a good experience for me to have because now I kind of know what to warn my patients about and kind of talk to them about my experience with it. So I obviously don't have anything to say about the reading or the ad power that I get from it, but the side effects I can speak towards. So I don't know how I really feel about them, honestly.
I think it's
depends
hard
on the patient
because we're just like not at that presbyopic point yet, so it's hard to kind of tell patients what to expect on that front.
For sure.
But I think a really good point about these drops is kind of just like setting the expectations for them and also letting them know about those side effects so that when they first put Viz in their eyes, like they're not going to be like, oh my God, like why did this burn? Like kind of just letting them know beforehand that those could be some of the side effects so they're not like scared when they first put a drop in.
Yeah, I can't remember. Does that go away like with time? Like the more you get used to using
it? That's what I've heard.
So.
Is I think like the first few times you use it, it can be a little bit, the drop can be a little bit spicy going in. But from what I've heard, it gets better. I don't know if you just get like more used to it, or I don't know.
Or you just kind of know what to expect. I don't know either.
Yeah.
Guess something we'll find out. I didn't really prescribe it too much because obviously like. We want patients to go to optical to buy glasses to help with just the overall profit of the office. So I don't have too much experience with it yet, but I definitely think it's a good thing to have on the market.
Yeah, I think it's a great tool, so.
Yes, I agree. And like we said, expectations, I feel like biggest one is one, side effects, but two, like I think a lot of people see the commercial for it or read about it on like the internet, and they think that, oh, I can just put in the drop and then I can see everything. But that's not always true depending on what age they're at and how much ad power they do need. So making sure patients understand that these are situational tools, I guess you would say, not magic drops that are going to replace your reading glasses forever.
Yeah, and I think that's kind of a point that you can make to patients too, that this isn't something that is going to make your up close vision like perfect by any means. It might be really good, especially when you're in the earlier days of presbyopia.
Yes.
But it's also important to have that pair of like reading glasses, as a backup.
Yeah,
like,
for sure.
This isn't like a replacement,
No, and it's probably also not ideal if you plan on, putting them in right before you're going to be driving at night, because then you really won't be able to see too well. With the dimming effect.
And actually, one thing that I heard too is that doctors, if they prescribe the Viz, that they'll give like Lumify too, or tell them to get some Lumify so that if they have any redness, that they can just put a drop of Lumify in, and hopefully that'll help kind of cut down with that redness. That's a good little clinical pearl, Lisa. Yeah. But again, like these drops might be great for something like a dinner out or going to a concert. Being able to read your phone while you're out, reading a menu, things like that.
Yeah, that's very true. Giving a presentation or something when you don't want to have to keep, doing the flip-flop.
Yeah, exactly.
And, it's not just making sure we know it's not for you every day to be
Yeah.
able to kind of look at your pill bottles in the middle of the night and see the
Yeah.
small kind of writing on them.
Yeah.
So patients
Yeah.
might be disappointed if you don't let them know that ahead of time.
Yeah, patient selection definitely matters. Someone who already has a small pupil or mild presbyopia, like we were kind of saying, like might absolutely love these drops.
Yes.
But like you said, like just someone who was trying to read that teeny tiny print.
Not for them, probably.
No,
But,
or
also not for the high myopes with the last generation either. You want to think twice before giving them the closey for sure. Viz is a little bit safer, so.
yeah, exactly. So moral of the story, these drops are cool. They're exciting. But again, they're not like a one size fits all. Kind of have to make sure you're doing those retinal exams and making sure they're fit candidate for this type of drop.
I agree with that 100%.
Yeah. Okay. So let's hear this hot take of yours.
Ooh, okay, yes, I'm excited. So my hot take is a little controversial, I'm not going to lie. So if you're listening to this and your opinion differs from mine, or mine and Lisa's, depending on what she thinks about it, or if you just have extra insight or perspective that you want to share, let us know, because we can always talk about this again. But this is just from kind of my own personal experience.
Yeah.
So,
all right. What is it? Let's hear it.
All right, so I think remote optometry is really great in certain settings, but I also think it really risks turning optometry into a bit of an assembly line if we're not really careful about when and how we use it.
Yeah, this was kind of everywhere at Academy too. When we
was.
were there, they kind of talked a lot about like remote optometry and stuff like that. We went to that big kind of lecture for it. So
yeah, we did. Yeah, they were teaching us and talking a lot about it. But for anyone who isn't familiar with remote optometry or doesn't kind of know what we're kind of chatting about, picture this. So it's a technician kind of running basically the whole exam. They're doing the entrance testing, and then they kind of do slit lamp videos, fundus photos, and then they kind of ship them off to the optometrist. And then either the optometrist themselves or a refracting technician kind of logs on remotely and does the refraction. Then the optometrist will review everything, all of the findings, and kind of sign off and then let you go.
Yeah.
But important to remember, the doctor might literally be in a completely different city or state. They're not just kind of sitting down the hallway in their office.
Yeah, so exactly. So it feels kind of like an in-person exam until you kind of realize that the OD isn't in the building. So it's kind of like a wild concept.
Yeah, it is. And I mean, the data is all there, but I feel like the biggest thing for me is like, where is that human connection? You can't always catch those little comments that patients end up making kind of when you're walking them out of the exam room or just randomly in conversation that really end up being important to kind of your treatment plan for them.
Yeah, totally. Like when a patient like casually says, "Oh, by the way, my eye's been twitching for 3 weeks," right as you're like about to end the exam and walk out of the room, or
yes, or the classic like, my vision is blurry only when I'm like laying down on the couch at night in my recliner. I cannot see the TV. And you suddenly have to like problem solve and say, well, like, are you tilting your chin up because you can't see the TV through your reading part of the glasses? So like, it's just things like that.
Yeah, exactly.
I mean, okay, I do, like, you let me know if you agree. I understand the model, though, like, in rural
100%.
clinics or really high volume, like, settings. I think it could help more patients get seen faster. But I feel like in kind of everyday optometry, places where, you know, access to care is accessible and readily available, I think it would be really cool for like screening exams or follow-ups or reviewing imaging. But I also think there should be like an age limit on there. I don't really think that 70 or 80-year-olds should be getting a remote exam. But
yeah, no, I definitely agree with like, I feel like it definitely is a place for like screenings. I feel like there's maybe a little bit of a different quality that you get with an in-person exam. But, you know, building that long-term patient relationship, that's a lot harder through a screen, I feel like.
It is.
I don't know that I would particularly love to get my eyes examined through a screen and know that the doctor isn't right there. But again, like, it's awesome for like those rural areas where they don't have a lot of doctors and don't have as much access to care. That's where it's super, I think, important.
Yeah, and I mean, I think for both of us too, we talked about last time, like we both kind of got into optometry because we like that patient connection part. But we both know there are patients sometimes that come in and they literally just will not engage in conversation no matter how many things I ask them or probe or just try to like make our time together less awkward. They just will not interact. So, you know, maybe it is good to have that option for people like that who literally just want their eyes looked at and then let them go. But I think for a lot of people and a lot of doctors, you know, it's the opposite. So to each their own, I guess.
Yeah, and I think too, like, doing remote exams, it allows you to be able to be like, they always say the doctor should be like the person that analyzes the data. So we're not actually like collecting the data, we're kind of analyzing it, which I think is a cool thing about the remote care as well.
But one thing about that I will say is when I was at a practice and they had this, but like if there was, you know, a 50 or 60-year-old that came in and through the fundus photos they found an ERM. Like they had to, the remote doctor couldn't do anything about that. Like they couldn't order an OCT. So then the patient had to schedule another appointment to come back in for dilation and OCT, which if we both know if there was an in-person exam, we could just do that while they were there. So
exactly.
That's why I think it should be kind of limited to who it's available to, I guess. But, you know, I'm sure it'll continue to evolve too over the next couple of years and stuff like that will kind of be fixed. But I think really, you know, it's about balance, and the concern again just becomes when it's the default instead of just another tool that we have in our toolbox.
I think that's a really important you know, thing to think about, like using it as, like we said, the screening in rural areas. This shouldn't become, I don't think it should become like a everyday thing where everybody should be getting remote exams.
I don't either, but you know what, if you disagree, that's what we're here for. So come debate us and share, you know, your feelings on the topic so we can, you know, learn more about the other side of it, because we only obviously have one perspective. So
exactly.
But speaking of, you know, the little conversations with patients that are most important part of the exam, you know, I think there's some other things that can happen in the exam other than patient complaints that we can find out that, you know, we need to kind of be addressing as well. I feel like when you actually are able to like talk to people, you learn so much about like what they need their vision for, how they're using it on a daily basis, things like that. I mean, I feel like it's not just, oh, here, let me do the refraction, what's your prescription? It's more like, what do you do all day? Are you on a computer? Are you is your computer a laptop, or is it a monitor? Is it one monitor, or two or three? You know, like, do you drive at night? Are you playing sports? There's so many questions that we have to ask in the exam to
or like what their job is, their hobbies, all the things that actually determine what kind of glasses or contacts are going to work best for their life. And one thing, I was actually on one of my externships, and one of the doctors, like, his main question was always like, what do they do with their eyes? Like, how do they use their eyes? And I think that was really great for him to kind of train his students on how to start asking that question, because it is honestly so important.
It is really important.
So that has now like become a part of my like, you know, history. Every time I'm with a patient is like, what are your hobbies? What do you do for work? Like all of that stuff. Because I mean, we use our eyes every day for all those things. So I think that's a really important thing to think about.
Yeah, and Lisa and I were talking about a really cool case that we saw through the Custom Stable Vision Project with Valley Contacts. So we wanted to kind of share the story a little bit with you guys so that you kind of understand why it's important to ask those questions and include that in your history like Lisa and I do.
Yeah, I feel like the story that we were kind of reading, it really kind of stuck with us. So kind of just want to talk more about it.
Yeah, so there was a patient that had keratoconus. She had already gone through corneal transplants in both eyes like several years ago. And after her surgery, it did improve the vision, and her glasses were functional, but honestly still not great. I think she was like 20/70 in one eye and like 20/40-ish in the other eye. So, you know, she can get around, but not fabulous.
Yeah, which, you know, for some people might be manageable, but
Yeah.
when you find out what she was doing for work,
Yes.
it kind of changes your whole thought process.
Yes. So if you didn't ask what she did for work, you'd be like, oh, great. Okay, goodbye.
Yeah.
But the doctor that saw her found out she was a police officer. So obviously having really sharp, stable vision, especially at nighttime,
Yeah.
is really important for her job
Yeah.
to be able to be comfortable doing it and do it appropriately.
Yeah, and that's kind of where the scleral lenses came in. With a custom stable scleral lens fit, her vision improved. Drumroll, please. It was 20/20 in both eyes, which is so great.
It's so good. And I think, like, it wasn't a video, it was just an article featuring her. So you can't, like, really, like, you can't hear her emotions, but just with, like, what she said, it was just, I don't know, it just pulled on my heartstrings. I think she said something like, oh my God, like, I can finally see, like, my life has been changed forever. And I think kind of both of us doing the specialty contact lens rotation at school and fitting sclerals and GPs, like, it really does, like, change some of these patients' lives and their vision, and it's crazy. So
it's
something for everyone, I feel like, to kind of look more into, you know?
Yeah, it's such a powerful reminder that specialty lenses aren't just about improving vision on a chart.
Yeah.
They can completely change someone's ability to work, drive, and live their life, especially for someone who's a police officer. I remember I've seen patients who were police officers, and they are having to read those tiny little driver's license numbers on the driver's license, like all that tiny print. Like, they need to be able to do that stuff, and seeing in the dark well, like, all of that is super important to that occupation.
Yes. So, you know, if you're interested in more stories like this, or if you have a story like this where you fit a specialty lens or any type of contact lens that kind of improved a patient's vision like this, and you want to share, let us know. Because we love little stories like this. It's what, you know, reminds me of kind of why my job is important. And I don't know, I think it's just exciting to be able to kind of, you know, increase a patient's ability to just literally do everything that they need to do on a day-to-day basis.
Yeah, and I think it, you know, puts into perspective too, like, why we got into optometry. Like, we're in this to help people's vision get better, help save vision, like, help do anything we can for people's vision to improve their quality of life.
Yes, for sure. So that was fun. So that's a cute little case.
Yeah.
But I think Lisa has a cool case to share with us that we were kind of chatting about earlier that we thought would be fun to kind of bring into the episode this month. So let's transition to our clinic confessions.
Yes. Okay. So I'm really excited for this one.
Yes, I'm excited too.
Yeah.
Take it away.
Okay. So this past week, I had a super interesting case involving proliferative diabetic retinopathy. But before we kind of get into the case a little bit more, let's just first, like, briefly talk about the grading system for diabetic retinopathy and how that all works, especially if we have, like, other students listening.
Yes.
I think that's a great thing because you're using this grading system. Like, if you're in a place who has a lot of ocular disease, like, you're going to use this every single day. So it's super important to know diabetic retinopathy grading and all of that.
Okay. I can just go over, like, the typical one, like mild, moderate. Okay. So
stages,
different, like, stages. So mild is when you see, like, less than or equal to, like, 1 MA. And then moderate is greater than 20 MAs, but less than, like, the 4-2-1 rule. And then severe is 1 criteria of the 4-2-1 rule, and then very severe is 2 or more criteria of the 4-2-1 rule, I think.
Yeah, you got it. Perfect. Lovely. So then let's kind of talk about the 4-2-1 rule and how that goes.
Yes.
So it's 4 quadrants of dot blot hemorrhages, 2 quadrants of venous beading, and 1 quadrant of IRMA. So for those students that might need help remembering this, I forget which professor had taught us this little, like, trick of how to kind of remember the 4-2-1 rule.
Oh, was it Dr. Labib?
It might have been. I think it might have been Dr.
Great slides.
She really did. But how I always remember this and how we were kind of taught is I should have written it down on a piece of paper to kind of show it.
Oh.
But basically, So with the H for hemorrhages, there's 4 points on the H. So you have 4 quadrants of hemorrhages. So 1,
Yes.
2, 3, 4 on the little H. And then venous beating. So you make a V. There's 2 little dots on the V. So 2 quadrants. And then for Irma, just a little I, 1 dot just up at the top. So 1 quadrant of Irma, if that kind of makes sense.
Yes, it does. I think you explained that beautifully. And shout out to, I believe, Dr. Labib for making that easy to just kind of stick in our brain and pull out whenever we need it.
Yeah, exactly.
And I guess, we kind of all know that these stages can also come with diabetic macular edema.
Yeah.
And then whether we have like PDR and PDR. So
Yeah,
also
and
something to think about.
yeah, and fun fact, DME, diabetic macular edema, is the most common cause of vision loss for these patients.
Yes.
And we know that duration is the biggest predictor for
Yes,
diabetic
it is.
retinopathy.
Yeah.
After 20 years, 99% of type 1 diabetics and 60% of type 2 diabetics will get some degree of retinopathy, which...
I didn't realize it was that high of a percentage for type 1 diabetics. That's really interesting.
Yeah, yeah, so...
Okay.
Nice little
well,
fact.
now that we did a quick little, learning overview, I am dying for you to share about your case.
Okay, so this was so crazy. I was so excited about this case. So this patient comes in and they're saying when they cover their one eye, they're seeing red out of the eye.
Yeah.
And I was like...
I'm going to pause you right there. Meanwhile, we're in clinic. She immediately texts me, "Oh my God, my patient's saying they're seeing red. What do you think it could be?" And
yeah, I was so nervous. I was like, oh my God, this has to be like a vid heme or a pre-retinal heme. Like, I'm freaking out right now. I'm going to look in there and whatever. So anyways, I go to look in the back of the eye and holy moly, he had a vid heme, let me tell you, pre-retinal heme. Like, it was crazy. And there was neovascularization, like, everywhere. He had NVI. It was just, I was shaking when I was doing 90. Like, literally, I was, like, shaking because I'd never seen this before. Like, I've only seen, like, mild, moderate diabetic retinopathy, maybe some macular edema. Like, I've never seen proliferative diabetic retinopathy.
Yeah.
So I was shaking in my little boots, and I was so excited to see this. I felt awful for the patient, obviously, but it was honestly like a super great learning experience, and we were able to get him right over to retina, which was really great.
Yeah.
So hopefully they gave this patient some treatment, but it was definitely a case that I will always remember. My first proliferative diabetic retinopathy case.
I think, didn't you, we FaceTimed, later that night so you could tell me about it? And didn't you say, you were, holding up your 90 or Superfield or something, and you were just, scanning and scanning and scanning, and you just red.
I didn't know where the hemorrhage ended. I was like, all right, I'm just going to keep going.
Yeah. I feel like that's something, you never get used to, and, that's just, the gut, your stomach just drops.
Oh, yeah.
Just,
And
where's the actual retina? What is happening?
Yeah, I went back to my preceptor, and I was like, so I think we got some proliferative diabetic retinopathy going on here, and good thing we took some fundus photos too, which was good just to have documented. But
yes,
yeah, it was super crazy case, but I'm really thankful I got to see it, just because I don't know how many times in your career you'll be able to see something so severe like that. So it was super great learning experience, which
that is exciting. I mean, you never know what you're going to see, and I think that's obviously exciting for us to see because we're interested in that, but it's also sometimes I feel like it's a little hard to control your excitement in front of the patient, or how scared you are, because you don't want to freak them out. Everything's going to be okay. We're going to obviously do the best to keep as much vision and get you back to as normal retina as we can, but
I think it's
a little
important to
weird kind of thing to deal with.
Yeah, I think it's important to just kind of try and stay calm, because in that moment in my brain, I was like, oh my God. And my hand was probably shaking so bad. But we got him, the patient is getting the care that they need. So I'm happy about that. So
yes. Yeah,
hopefully.
that's the most important part.
Yes. Yeah, exactly. All right, so let's shift gears a little bit and let's
Okay.
talk about a topic that is always evolving.
Yeah.
And that is our dry eye management.
Yes. Oh my God. From IPL and radio frequency to all the new medications,
Yeah.
I feel like the dry eye world has really exploded in options in the past few years, which is really exciting.
Yeah, it definitely has. Even just since we've been in school, we've been able to see new things kind of hit the market, like
Yes.
MIBO, XDEMVY.
Yes.
And honestly, those two have some pretty killer commercials,
Yes.
if I could say so myself.
Yes, especially XDEMVY. Do you, how many patients and even family members, literally my brother was visiting my grandpa, a couple weeks ago, and he called me and he was like, Pop
Stop.
wants to know if he has mites in his eyelashes. And I'm like, well, I don't know. I can't just tell you over the phone. So I was like, next time you go to the VA, because he's a veteran, just go into the eye clinic and see.
Yeah.
So next time he goes, he's going to go check. And he asked because he saw the XDEMVY commercial. So
Yeah, I think the funny part about getting to the end of our schooling now is our family members are starting to ask us questions and text us what's going on with my eye? I'm like, I don't know. I need to see you in person underneath the slit lamp.
Yes.
I can't diagnose you with literally just having a completely blurry picture of your eyeball.
Yeah. Or
Please.
it's half in the frame.
Yeah.
No, this is not selfie. I cannot treat you off of a selfie right now.
No.
Also, that's the part that also sucks. I literally can't treat you yet. I can probably tell you what you have, maybe.
Yeah.
I literally can't do anything about it. So just go see the doctor, and then in a few months, I will gladly treat you. But right now, I really can't do anything.
Yeah, through the phone, there's not too much I can do. But yeah, we can't, prescribe anything. So it's kind of I can tell you what you might have. But again, I need to see your actual eyeballs.
Go see someone else. Yes.
Yeah. Yeah, but also with the whole patients coming in and asking about if they have mites in their eyes, I've had so many people ask me about that as well because of that commercial, which honestly, great marketing.
Yes.
But it's also been so wild.
Yeah, it has. And honestly, great marketing for them, but it's also really great that patients are becoming more aware. They know to ask, or I feel sometimes they think that something isn't relevant to the exam, but it is. So now I feel a lot more patients are saying oh, my eyes are itchy and red in the morning, especially and that's something that we know to kind of look more for and something that we would actually treat versus if they just have some lash debris, we're not gonna necessarily give them something right away if they're not complaining. So
yeah, for sure.
And I've seen a lot of patients, and I've prescribed XDEMVY to a lot of the patients, and it's I've been amazed at the 6 week difference, and when they come back in, their lashes are literally clean, and before they had so much Demodex and so much just debris in their lashes. So it works really well, which is great.
Yeah, I agree. I've seen some really impressive improvements in patients.
Yeah.
And I think what's so exciting about it is that it really is the first medication kind of its kind that actually targets the Demodex directly. So I think that's what's kind of so exciting about these new medications and these drug companies wanting to help improve patients' quality of life with things like this.
Yes, and it makes it more exciting for us too, because it shows just how much dry eye treatment has evolved, and we're not just telling them, oh, use preservative-free artificial tears 4 times a day.
Yeah.
Now we can give them something to actually target the underlying cause instead of just telling them to clean their eyelashes. So.
Yeah. And speaking of that, I was able to see a lot of really cool results with IPL during my last rotation, which I enjoyed so much. I loved it.
Yeah. Dry eye is something that I really like and I'm really interested in, but unfortunately
same,
none of my rotations have had dry eye specialties in them, so I haven't gotten to use IPL or anything like that. So I'm hoping that I can find a job at a place that maybe has that, so I can kind of learn more about it, and but I always enjoy hearing the results that you get and how excited you are to see your patients coming back in between treatments and how they're improving. And same thing with some of my other friends, and then my best friend in undergrad. She had like severe dry eye. And I was talking with her a couple weeks ago, and she actually had IPL, and it literally solved all of her problems. And I was so excited for her because she literally would wear like 5 contact lenses a day because they would just dry up and fall out of her eyes. So,
which is so awful. So like, I kind of love that optometry is kind of dipping its toes into more of like the aesthetics kind of thing.
Yes.
So I kind of want to talk, excuse me, I kind of had a patient, I had a patient where I was doing their second and third IPL sessions when I came into my last rotation. And so after the second, third, and fourth, sessions, we do manual expression of the glands.
Yeah.
And so after that second and third session, the one eye had some like really thick meibum, but we were able to express it quite a bit. While the other eye was just a little bit more like stubborn and barely expressed anything. But oh my gosh.
I feel like that's always how it goes though. Like it's either really gonna squirt right out at you, or you're gonna push and push and push, and it's just not. It's too stubborn.
And then the patient came back for their next treatment, and suddenly that stubborn eye started expressing a lot more thick meibum.
Just makes it like 20 times better when it's really stuck and it decides to.
And I have to admit, manual expression might like secretly be my favorite part of the whole process. And my last preceptor, he would kind of make fun of me because I would get so excited to do the manual expression. You can just see like literally how much I loved it and how excited I got when I would do it.
Okay, Dr. Meibomian Gland Popper over here. We are moving from podcast to network TV.
Yeah. Yeah, literally.
Find us on Hulu.
Yeah, that would be so funny. And I know that probably sounds like so weird to the non-eye people because it literally is like a Dr. Pimple Popper like
it really is.
Kind of thing. Like it's so thrilling. Like I don't do you find that thrilling? I do.
Obviously.
I don't know, it's just so fun.
It's fun to do the expression, and it's so satisfying.
Yeah.
But it's also really satisfying when you just see the glands finally are working again and know that your patient is going to get literally so much relief from it. And I think that's, the biggest shift with dry eye now. We're actually treating the root of the problem. So whether it's inflammation or it's gland dysfunction or even Demodex, we have tools to address what's really going on and can get patients relief a lot sooner, I think.
Yeah, and patients notice that difference.
Yes, they do.
It's very apparent. I mean, maybe not after the very first session, but once you get to that second, third, you can tell that these patients feel a lot better. And I mean, I've had patients too, after their first time, they've actually said their eyes have,
they can already notice.
Yeah, a little bit of a difference.
That's great.
But it's
so that's IPL.
Yeah.
And you've done some radio frequency too, right?
I've seen it being done. I didn't actually get to do it myself, but I've seen it be done a little bit.
Are you able to kind of share a little bit about that? Because I feel I know more about IPL than I do about radio frequency.
Yeah.
So I'd like to just
Yeah. So I kind of like to explain radio frequency as a warm compress on steroids. You just kind of rub this little probe over the eyelids and kind of target the glands. A lot of eye doctors are doing the radio frequency and IPL together because you get the IPL that helps to get the inflammation that's caused by the dry, and then you use the radio frequency to help those glands even more to be able to express better.
Oh, yeah. Okay. So then, that makes sense. Putting the procedures together is a really great idea because you're targeting the root of the dryness in both ways and just helping it kind of, express a little bit better. And
it's a little
not have to wait between so many treatments.
Meibomian gland cocktail.
Yeah, I love that.
And it's relaxing.
And I feel like something we also need to address if we're going to talk about dry eye is the fact that it's not just in the old patients anymore. I feel like every patient I see, 15-year-olds, 16-year-olds, they all have like some type of dry eye, or they have the start of like meibomian gland dysfunction or stuff like that. So I think between so much screen time and contact lenses and makeup and lash extensions on some of these patients, we're just, dry eye is getting younger and younger these days.
Yeah. And again, like when we were talking about how we ask what people do for work and stuff, like I always ask like how long patients are on the computer each day. Because there's actually a stat that like our blink rate drops basically in half when we're staring at our computer screens and our phones all day.
I mean, I believe it. I feel it. Like those long days when we were studying, like my eyes just felt like they were like the Sahara Desert or something.
Yeah, literally. Yeah.
And I don't know. I feel like all of it sounds simple, but reminding patients to blink and take breaks can, make a big difference. Yeah. Whether they listen or not, I don't know. But I make sure to always tell them, like, just give your eyes a little bit of a rest. Be more conscious. Yes. And then some of the more severe cases, especially contact lenses, can also be a part of that conversation. Amniotic membranes, stuff like that.
Yeah, so. A lot of people think scleral lenses are only for like vision correction, but they can also be amazing for like ocular surface disease, like especially like super severe dry eye.
Yeah, they create that little like fluid reservoir over the cornea that just like a little bath for the eyeball throughout the whole day. I feel like there's several people in our class that kind of got sclerals through the specialty contact lens department for that. Yeah. So.
And even if you're not fitting scleral lenses yourself, just like knowing when to refer a dry eye patient for a specialty lens evaluation can make a huge difference for them. Yeah,
definitely. I mean, I feel like everything we've talked about has just showed how dry eye management has become so like multidisciplinary, from medications and now we have in-office procedures and lifestyle changes and just specialty lenses kind of all working together. It's like a big mix of so many things, which is a little overwhelming for me because I haven't had like too much experience with dry eye, but I think something that just kind of comes with time, right?
And honestly, that's kind of what makes it exciting now. It used to feel so frustrating because there really weren't many options. It was like artificial tears and that's it. But now it's more like solving a puzzle, figuring out what type of dry eye the patient has and building a treatment plan that kind of actually works with them and works for them. And I think that's, a really great thing of how dry eye has kind of been evolving, and it's just so interesting. And I loved doing, dry eye workups and stuff like that at my one rotation. It was a lot of fun, and I kind of love dry eye. It's been a cool thing to like learn about and get more exposure with.
Hopefully it's something you get to keep on doing for the rest of your journey.
Yeah.
But I mean, I feel like, with all this being said, the main goal obviously is to get the patient more comfortable. Yes. So when they come in for their next appointment and they say, they can read for several hours, or they can drive, or just honestly get through their normal workday without constantly thinking about their eyes and how uncomfortable they are, that's a huge win in itself.
No, I think that's definitely a huge part of all of this, and it's definitely a win for the patient.
Yeah. All right, Lisa, looks like it may be about that time. Is there anything else we want to chat about before we wrap it up?
No, I think we kind of covered everything that we wanted to today.
Yeah, I think so too. All right, well, that's it for episode 2.
Yeah, so don't forget, we want you to join the conversation. Yes. Reach out to us by email and follow us on Instagram if you would like. We would love for that to happen.
Yes.
So our Instagram is Blink Collective, so you don't miss any like new episodes. And on TikTok, I think it's Blink Collective Podcast. So follow us.
Wait, actually, I think it's opposite. I think Instagram is Blink Collective Podcast.
And then TikTok is Blink Collective.
Collective.
You're right. Yeah, you're right.
And then I think it's just Blink Collective on YouTube as well. So, yeah.
Give us a follow.
It's a something of what we just said, so search all of it.
If you search Blink Collective in Instagram, you'll definitely be able to find us. You'll see our faces.
Yes. Our gorgeous, beautiful faces. being so silly.
Yeah.
Who even knows? So, if there's a topic you want covered, a story you want to share, or a hot take you're dying to get off your chest, or you want to debate one of our hot takes, this is your mic too. Don't forget.
Yep. Blink Collective isn't just a podcast you listen to. It's a community where students and young ODs' voices matter. So always remember.
Yes. Absolutely. So make sure you share this with a friend, and remember,
You don't have to have it all figured out, because we certainly don't.
Nope. No, you just have to keep showing up. So we'll see you next time
on Blink Collective.
Blink Collective.